Alright everyone, welcome. Today we're diving deep into a part of the body we use every single second of the day, yet probably don't think about nearly enough: the tongue. It's easy to dismiss it as just a simple muscle that helps us talk and eat, but trust me, it's so much more complex and fascinating than that. The tongue is a powerhouse of coordinated function, a muscular hydrostat that allows for an incredible range of movements without a single bone to support it. Think about that for a second. It's strong enough to crush food against the roof of your mouth, yet delicate enough to detect the tiniest crumb. It's a true marvel of biological engineering, and understanding its anatomy is fundamental for any of you heading into the medical field. This organ is your primary tool for taste, allowing you to enjoy that morning coffee or a well-deserved pizza. But its job description doesn't stop there. It's absolutely crucial for mastication, which is the fancy term for chewing. The tongue expertly maneuvers food around the mouth, positioning it perfectly between your teeth for grinding. Then, it plays the leading role in deglutition or swallowing, by pushing the bolus of food back into the pharynx. And let's not forget its role in articulation. Without the precise movements of your tongue, forming words to communicate would be impossible. So, from your first words as a child to savoring your favorite meal, the tongue is the unsung hero working tirelessly behind the scenes. As future doctors, nurses, dentists, and healthcare professionals, you'll find that the tongue is also a vital diagnostic tool. It can act as a window into a patient's overall health, showing signs of dehydration, nutritional deficiencies, infections, and even systemic diseases. A quick look at the tongue can give you valuable clues long before other symptoms appear. That's why a thorough oral examination is a cornerstone of any good physical assessment. Knowing the difference between a healthy tongue and one that's signaling trouble comes from a solid understanding of its underlying anatomy and physiology. We're going to build that foundation together, piece by piece. In this guide, we're going to break it all down. We'll explore its different parts, the muscles that give it shape and movement, the blood vessels that keep it nourished, and the nerves that control it all. We'll make it simple and clear, so you can walk away with the confidence to apply this knowledge in a clinical setting. Forget memorizing endless lists of jargon for a moment. Instead, let's focus on understanding how this incredible organ works, why it's structured the way it is, and what that means for your future patients. So, grab your notebooks, get focused, and let's begin our journey into the amazing anatomy of the tongue. Let's start by getting our bearings. Think of the tongue as a muscular island in the oral cavity. It has a few key landmarks you need to know. First, we divide it into two main parts. The anterior 2/3 is called the oral part, or body of the tongue. This is the section you can stick out and see in the mirror. It's the mobile, busy part involved in taste, chewing, and speaking. The posterior 1/3 is known as the pharyngeal part, or the root of the tongue. This part is fixed and forms the anterior wall of the oropharynx. You can't see it without special instruments, but it's critical for swallowing. These two sections aren't just arbitrarily divided. Their different developmental origins are why they have distinct nerve supplies, which we'll cover later. Separating the oral and pharyngeal parts is a V-shaped groove on the superior surface, or dorsum, of the tongue. This groove is called the sulcus terminalis. It's a really important landmark. At the apex of this V, pointing backwards, is a small pit called the foramen caecum. This little pit is a remnant from embryonic development, marking the point where the thyroid gland began its descent down into the neck. So, when you see the foramen caecum, you're looking at a tiny piece of your own developmental history, which is pretty cool. It's a constant reminder of how interconnected our body's structures are from the very beginning. Now, let's look at the surfaces. The top surface, the dorsum, is the one you're most familiar with. It's rough and covered in tiny bumps called papillae, which we'll get to in a moment. This is where your taste buds live. The dorsum is also divided down the middle by a gentle depression known as the median sulcus, which corresponds to the fibrous septum that separates the muscles on the left and right sides. Flipping the tongue up reveals the inferior surface. It's smooth, purplish, and connected to the floor of the mouth by a midline fold of mucous membrane called the lingual frenulum. If this frenulum is too short, it can restrict tongue movement, a condition known as ankyloglossia, or tongue tie. Finally, at the very back, on the pharyngeal part of the tongue, the surface isn't smooth. It's covered in lumpy nodules of lymphatic tissue. These are the lingual tonsils. Along with the palatine and pharyngeal tonsils, they form Waldeyer's ring, a circle of lymphoid tissue that acts as the first line of defense against pathogens entering through the mouth and nose. So, the root of your tongue is not just for swallowing. It's an active part of your immune system, standing guard against infections. Understanding this basic geography is the first step to mastering the tongue's more complex functions and clinical relevance. It provides the map we need for the rest of our exploration. Let's zoom in on the dorsum of the tongue and talk about those little bumps I mentioned, the papillae. These aren't just random textures, they are highly specialized structures that serve different purposes, primarily related to taste and touch. There are 4 types of papillae, and you need to know them all. The first and most numerous are the filiform papillae. These are small cone-shaped projections that cover most of the anterior 2/3 of the tongue. They are keratinized, which gives them a rough, abrasive texture, almost like a cat's tongue. This roughness helps create friction, allowing the tongue to grip food and move it around the mouth effectively during chewing. Importantly, filiform papillae do not contain any taste buds. Their job is purely mechanical. Next up, we have the fungiform papillae. As their name suggests, these are mushroom-shaped. They are scattered amongst the filiform papillae, but you'll find them in higher concentrations at the tip and along the sides of the tongue. They appear as small red dots because of their rich blood supply, which is visible through the thin epithelium covering them. Unlike their filiform neighbors, fungiform papillae do contain taste buds, typically located on their top surface. They are our primary receptors for sweet and salty tastes, which is why you often perceive those flavors most intensely at the tip of your tongue. They contribute significantly to the rich tapestry of flavors we experience with every meal. Then there are the foliate papillae. These are found on the posterolateral borders of the tongue, appearing as a series of parallel ridges or folds. If you look at the side of your tongue in the mirror, you might just be able to see them. They are more prominent in children and tend to diminish with age. The foliate papillae are packed with taste buds nestled into their folds and are particularly sensitive to sour tastes. Their location on the sides of the tongue means they are perfectly positioned to detect the acidic compounds in our food as we chew and manipulate the bolus, providing critical sensory feedback during the process of mastication. Finally, we come to the largest but least numerous of the papillae, the circumvallate or vallate papillae. There are usually only about 8 to 12 of them, arranged in that V shape just in front of the sulcus terminalis. They are large circular structures surrounded by a deep, moat-like trench or vallum. The walls of this trench are lined with thousands of taste buds. Secretions from minor salivary glands, known as von Ebner's glands, continuously flush out this trench. This ensures that old taste stimuli are washed away, allowing the taste buds to respond to new ones. These papillae are especially sensitive to bitter tastes, and their posterior location is thought to be a protective mechanism, allowing us to detect and potentially reject toxic substances before swallowing. Now that we've mapped the surface, let's explore what's underneath. The bulk of the tongue is made of muscle, which we can split into 2 groups, intrinsic and extrinsic. The intrinsic muscles are the ones that are contained entirely within the tongue. They don't attach to any bone. Their job is to alter the shape of the tongue, making it longer, shorter, wider, or flatter. These fine, precise movements are essential for both speech and swallowing. There are 4 pairs of intrinsic muscles, and they work in beautiful concert to give the tongue its incredible dexterity. Think of them as the tongue's internal sculptors, constantly remodeling it as needed. The first pair is the superior longitudinal muscle. This is a thin layer of muscle fibers running just beneath the mucous membrane on the dorsum of the tongue, from back to front. When these muscles contract, they shorten the tongue and cause the tip and sides to curl upwards. This action helps to form a trough in the middle of the tongue, which is useful for holding liquids or directing the food bolus towards the back of the mouth for swallowing. It's a key player in the initial phase of deglutition and helps shape the tongue for producing certain speech sounds. Directly opposite, on the underside of the tongue, we have the inferior longitudinal muscle. This pair also runs from the root to the apex of the tongue. When it contracts, it works with the superior longitudinal muscle to shorten the tongue. However, its primary individual action is to pull the tip of the tongue downwards and cause the dorsum to become convex, or bulge upwards. The coordinated action of the superior and inferior longitudinal muscles allows for the complex curling and uncurling motions you use when, for example, you're trying to get a stray piece of food off your lip. The final 2 pairs of intrinsic muscles are the transverse and vertical muscles. The transverse muscle fibers run horizontally from the median fibrous septum to the sides of the tongue. When they contract, they pull the sides of the tongue towards the midline, causing the tongue to narrow and elongate. This is the muscle you use when you poke your tongue out. The vertical muscle fibers run from the dorsal surface to the ventral surface. Their contraction flattens and broadens the tongue, pressing it against the floor of the mouth. Together, these four pairs of intrinsic muscles give the tongue its unique ability to change shape so dramatically and precisely. If the intrinsic muscles are the sculptors, the extrinsic muscles are the movers. These are the muscles that originate from structures outside the tongue, namely, bones in the skull and neck, and insert into the tongue. Their main function is to change the position of the tongue as a whole, moving it up, down, forwards, and backwards. There are four pairs of these powerful muscles, and well, their names conveniently tell you where they originate and insert. Understanding these is crucial for appreciating how the tongue moves within the oral cavity and pharynx. These are the muscles that do the heavy lifting for protrusion, retraction, elevation, and depression. First, let's talk about the genioglossus. This is the largest and strongest of the extrinsic muscles, and it does most of the work. It originates from the superior mental spine on the inner surface of the mandible, your jawbone, and fans out to insert into the entire length of the tongue's dorsum. Its posterior fibers pull the tongue forward, causing it to protrude out of the mouth. This is a clinically important action. If the nerve supplying this muscle is damaged, the tongue will fall back and obstruct the airway. The anterior fibers work to retract the tip, while contracting the whole muscle together depresses the central part of the tongue, creating a channel. Next is the hyoglossus. As its name suggests, it originates from the hyoid bone, that unique U-shaped bone in your neck, and inserts into the side of the tongue. The hyoglossus is a broad, flat muscle. When it contracts, it has a straightforward action. It depresses the tongue, pulling it downwards and slightly backwards. This action is important for opening up the oral cavity during breathing and for positioning food during chewing. It works in opposition to other muscles that elevate the tongue, allowing for fine control over its vertical position. Then we have the styloglossus. This muscle arises from the styloid process, a pointy projection of the temporal bone of the skull, located just behind your ear. From there, it runs downwards and forwards to insert into the side of the tongue, intermingling with the fibers of the hyoglossus. When the styloglossus contracts, it pulls the tongue upwards and backwards. This retraction movement is essential for the second phase of swallowing, where the tongue pushes the bolus of food into the pharynx. It's the primary retractor of the tongue, pulling it back into the oral cavity after protrusion. Finally, there's the palatoglossus. This one is a bit unique because it's technically a muscle of the soft palate, but it acts on the tongue. It originates from the palatine aponeurosis of the soft palate and descends to insert into the side of the tongue. When it contracts, it elevates the posterior part of the tongue. It can also depress the soft palate, effectively narrowing the opening between the oral cavity and the oropharynx, which is called the oropharyngeal isthmus. This action is vital for sealing off the oral cavity from the pharynx during chewing, so you don't accidentally swallow your food before you're ready. Like any hard-working muscle, the tongue needs a robust and reliable blood supply to deliver oxygen and nutrients and to remove waste products. This circulatory network is relatively straightforward, dominated by one main artery and its corresponding veins. The primary arterial supply to the tongue comes from the lingual artery. This artery is a major branch of the external carotid artery, one of the two large arteries in your neck that you can feel pulsating. The lingual artery arises from the external carotid at the level of the hyoid bone and takes a winding path to reach the tongue, passing deep to the hyoglossus muscle. This tortuous course allows the artery to accommodate the tongue's extreme movements without being stretched or damaged. Once it reaches the tongue, the lingual artery gives off several branches. The dorsal lingual arteries supply the root of the tongue, including the lingual tonsils and the epiglottis. The deep lingual artery is the terminal branch, running along the inferior surface of the tongue all the way to the tip. It supplies the body and apex of the tongue. Finally, the sublingual artery branches off to supply the sublingual salivary gland and the floor of the mouth. This rich anastomotic network ensures that the entire tongue receives ample blood flow, which is essential for its high metabolic activity and rapid healing capabilities. Venous drainage, the process of returning deoxygenated blood back to the heart, largely mirrors the arterial supply. The main veins involved are the deep lingual vein, the dorsal lingual veins, and the sublingual vein. The deep lingual vein, which is often visible as a prominent blue line on the underside of the tongue, runs alongside the deep lingual artery and drains the apex and body. the dorsal lingual veins drain the root and dorsum of the tongue. These veins ultimately converge and follow a path similar to the lingual artery. These smaller veins typically drain into the main lingual vein. The lingual vein then accompanies the lingual artery for part of its course before draining into the internal jugular vein, which is the large vein in the neck responsible for carrying deoxygenated blood from the head and neck back towards the heart. Understanding this vascular map is critical in a clinical context, especially during surgical procedures involving the floor of the mouth or the tongue itself. It's also relevant when considering the rapid absorption of certain sublingual medications, which can enter the bloodstream quickly via the rich venous plexus under the tongue. The nerve supply to the tongue is arguably the most complex part of its anatomy, but we can break it down logically. We need to consider two different things: motor innervation, which controls muscle movement, and sensory innervation, which deals with touch, pain, temperature, and taste. A key thing to remember is that the division between the anterior 2/3 and the posterior 1/3, marked by the sulcus terminalis, is crucial here, as they have different sensory nerve supplies due to their different embryological origins. Let's tackle the motor supply first, as it's the most straightforward. It's all about one very important cranial nerve. With one small exception, all of the muscles of the tongue, both intrinsic and extrinsic, are innervated by the hypoglossal nerve, which is cranial nerve 12. This nerve originates from the brainstem and travels down through the neck to enter the tongue from below. Its name literally means under the tongue. If the hypoglossal nerve on one side is damaged, the muscles on that same side will become paralyzed. When the patient is asked to stick their tongue out, the unopposed action of the healthy genioglossus muscle on the other side will cause the tongue to deviate towards the damaged side. This is a classic clinical sign. The one exception is the palatoglossus muscle, which as a muscle of the palate is supplied by the pharyngeal plexus, receiving its fibers from the vagus nerve, cranial nerve 10. Now for the sensory supply, which is a bit more involved. Let's start with the anterior 2/3. General sensation here, that's touch, pain, and temperature, is provided by the lingual nerve. The lingual nerve is a branch of the mandibular division of the trigeminal nerve, cranial nerve V3. But what about taste? Special sensation, or taste, for this same interior part is carried by a different nerve, the chorda tympani. This is a branch of the facial nerve, cranial nerve 7, that cleverly hitches a ride with the lingual nerve to reach the tongue. So, two different cranial nerves are responsible for sensation in the front part of your tongue. Moving to the posterior 1/3 of the tongue, things get a little simpler. For the area behind the sulcus terminalis, both general sensation, touch, pain, temperature, and special sensation, taste, particularly for bitter flavors, are supplied by just one nerve, the glossopharyngeal nerve, cranial nerve 9. This nerve is also responsible for the gag reflex, which is triggered when the back of the tongue is stimulated. A tiny bit of the tongue right at the very back, near the epiglottis, receives some sensory fibers from the internal laryngeal branch of the vagus nerve, cranial nerve 10. This complex arrangement of nerves is a beautiful example of how different functional systems are layered onto a single anatomical structure. Understanding the tongue's anatomy isn't just an academic exercise, it's absolutely vital in clinical practice. The tongue can provide a wealth of information about a patient's health. For example, a condition called glossitis, which is inflammation of the tongue, can cause it to become swollen, smooth, and discolored. This can be a sign of nutritional deficiencies, such as a lack of iron, vitamin B12, or folate. A pale, smooth tongue might point towards anemia, while a bright red or strawberry tongue can be a sign of scarlet fever or Kawasaki disease in children. As a clinician, being able to recognize these signs can help you form a differential diagnosis and order the right tests. Oral cancers are another major area where tongue anatomy is critical. Squamous cell carcinoma is the most common type of cancer to affect the tongue, and it most frequently occurs on the posterolateral borders. Early detection is key to a good prognosis, so a thorough examination of all surfaces of the tongue, including the sides and the underside, is a non-negotiable part of any oral health check. Knowledge of the lymphatic drainage of the tongue is also essential here. Cancer cells can metastasize or spread through the lymphatic system to the lymph nodes in the neck. Understanding which nodes drain which part of the tongue helps surgeons plan resections and radiologists target treatments effectively. We've already touched on nerve damage, but it's worth emphasizing. A lesion of the hypoglossal nerve, cranial nerve 12, leading to that characteristic tongue deviation is a hard sign of neurological damage that you cannot miss. Similarly, testing the different sensory modalities on the tongue can help you localize a lesion in the brainstem or along the path of the cranial nerves. If a patient reports a loss of taste on one side of their tongue, you need to think about the facial nerve, cranial nerve 7, and the chorda tympani. If they can't feel touch on the tip of their tongue, you'd be thinking about the trigeminal nerve, cranial nerve 5. This is applied neuroanatomy at its finest. Finally, the anatomy of the tongue is fundamental in airway management. In an unconscious patient, particularly when they are lying on their back, the genioglossus muscle can relax completely. This causes the tongue to fall back and obstruct the oropharynx, blocking the airway. This is a life-threatening emergency. Simple maneuvers like a head tilt chin lift or a jaw thrust are designed specifically to pull the tongue forward and open the airway. Furthermore, knowledge of the structures at the root of the tongue, like the epiglottis and vallecula, is essential for anyone performing intubation. The tongue is not just an organ of speech and taste, it's a gatekeeper to the airway, and managing it correctly can be the difference between life and death. So there you have it, a grand tour of the tongue from its bumpy surface right down to its muscular core. We've seen that it's not just one muscle, but a sophisticated collection of 8 pairs of muscles controlled by a complex web of nerves. We've traced the path of the arteries and veins that keep it working and explored how its surface is exquisitely designed for taste and texture. I hope you now have a much deeper appreciation for this incredible organ and feel more confident in your understanding of its structure and function. This knowledge is not just for exams, it's a practical toolkit that you will use throughout your entire medical career. Remember, anatomy is the language of medicine. The more fluently you speak it, the better you will be able to understand, diagnose, and treat your patients. Every detail matters. The location of a nerve, the path of an artery, the function of a muscle. These are the facts that will underpin your clinical decisions. Take the time to really visualize these structures, use diagrams, watch videos, and even look at your own tongue in the mirror. Connect the textbook knowledge to the living, breathing anatomy. This is how you build a foundation that will last a lifetime, long after the details of a lecture have faded. This is just the beginning of your journey. The human body is full of amazing systems and structures just waiting to be explored. Keep that curiosity alive. Ask questions, challenge what you know, and never stop learning. Every patient you meet will be a new opportunity to apply this knowledge and make a real difference. Your dedication to mastering subjects like anatomy now will pay huge dividends in the future, both for you and for the people who will be in your care. You are building the expertise that will one day save lives, and that is an incredible privilege. If you found this guide helpful and want to continue building your medical knowledge with clear, straightforward explanations, then I warmly invite you to check out what we're doing over at Joen Academy. We are passionate about making medical education accessible and engaging for students just like you. We have a whole library of resources designed to help you succeed on your path to becoming an outstanding healthcare professional. Thanks for joining me today. Keep up the great work, stay curious, and I'll see you in the next one.